Hey everyone, and a huge welcome to all the medical coding students joining us today. If you're looking to conquer CPT coding for fine needle aspiration and core needle biopsy, you are exactly where you need to be. We all know these minor invasive tests are absolutely vital frontline tools for diagnosing things like cancer, infections, and inflammatory diseases. Doctors rely on them every single day to grab samples from suspicious masses, but while they're fast and clinically amazing, coding these procedures, it's not always a walk in the park. It requires serious focus and a really solid grasp of the rulebook. So grab your notebooks, because by the end of this explainer, we're going to make sure your coding accuracy is completely bulletproof. Let's dive in.
Here is our roadmap for today's explainer. We'll start with FNA and CNB fundamentals, hit the essential CPT rules, dive into mastering modifier 5.9, and wrap up with some real-world case studies covering both FNA and mixed scenarios.
All right, Section 1, FNA and CNB fundamentals, looking at the core clinical differences.
When you're staring down clinical documentation, you really have to pinpoint the primary goal of the test. A fine needle aspiration, or FNA, is designed to pull out pellets of a loose cellular suspension. The lab uses this for a cytological examination, which basically means they are just looking at individual loose cells. On the flip side, a core needle biopsy, or CNB, gives you a significantly larger amount of tissue. This is for a histopathological investigation. The pathologist isn't just looking at floating cells here, they're actually studying the physical structure and layout of the diseased tissue.
Let's break down the mechanics of an FNA. It's this fast, definitive method for diagnosing lumps and bumps using a very fine, hollow needle attached to a syringe. First, the physician introduces this needle into the mass. They might do this entirely by feel, or they might use imaging guidance to hit the exact right spot. Step 2, the needle is withdrawn, and that loose cellular material is spread right onto a glass slide. Step 3, they color it with special dyes and look at it under a microscope. It's a beautifully simple 3-step process.
Now, what's really interesting is the totally distinct purpose of the core needle biopsy. Because the provider needs that larger sample we talked about, this procedure is all about capturing the actual tumor's architecture. You're grabbing a solid core of tissue to really see how those cells are structured and connected pathologically.
So the CNB process is just a bit heavier. Step 1, the physician removes a solid cylinder of tissue from a suspicious area, usually under imaging guidance. The instrument here isn't just a basic syringe, it's a percutaneous needle equipped with an actual cutter. And that cutter is crucial because it physically slices out that core sample. Step 2, this intact tissue cylinder is sent to a lab for a deep analysis, generating a comprehensive physician report. Also, just keep in the back of your mind that CPT codes for CNBs are chapter-specific. Moving right along to Section 2, Essential CPT Coding Rules.
Let's lay out the basic code blocks for FNA. You absolutely have to memorize these distinctions. If a physician performs an FNA on an initial lesion with no imaging guidance, you're going to use code 10021. If they biopsy subsequent lesions, again with no guidance, you use the add-on code 10004. But, and this is a big but, the second an imaging modality comes into play, like ultrasound or fluoroscopy, you shift entirely over to the 10005 through 10012 code family. And that goes for both your first and subsequent lesions. Identifying whether imaging guidance was used or not is literally the first fork in the road for your coding. I really want to emphasize this rule. These codes are reported once per lesion per session. You absolutely do not bill a code 3 times just because the doctor took 3 passes at the exact same lesion. For second and subsequent lesions, you must use those specific add-on codes we just talked about. Plus, when you're coding an FNA with those imaging-specific codes, the imaging guidance is inherently bundled right in. It is not reported separately, so whatever you do, do not double bill that imaging.
All right, Section 3, Mastering Modifier 59.
So the crucial thing here is knowing exactly when the rules legally allow you to use modifier 59, which stands for a distinct procedural service. You append modifier 59 to tell the insurance payer, hey look, this wasn't an accident or a duplicate bill. You can use it to report a completely different procedure or surgery, a totally different site or organ system, a separate incision or excision, a separate lesion, or even a separate injury that was handled during the exact same session as the initial procedure.
But listen up, because here is the hard and fast rule I want all you future coders to burn into your memory right now. Do not, under any circumstances, use modifier 59 with add-on codes.
period. And never, ever use it just to bypass a coding edit to force a claim through. It is meant exclusively for truly distinct procedural services. Misusing it is a massive compliance risk, and you definitely don't want that kind of heat. Okay, we're about to tackle the heavy lifting of real-world scenarios. Are you ready to test your coding skills? Take a quick second to stretch your legs, and while you do, please hit that like button on this explainer and subscribe to my YouTube channel for daily coding updates. Your support is what helps us keep bringing this specialized education right to you. All right, let's get back into it.
Section 4. Let's look at some FNA case studies.
Let's walk through example 1. Picture a patient with 2 suspicious lesions. The physician performs an FNA on lesion 1 in the thyroid using ultrasound guidance. Then they move on and do an FNA on lesion 2 in the cervical region, but this time they use fluoroscopic guidance. Here is the key takeaway. We have 2 different lesions and 2 different guidance methods. Because the guidance methods actually changed, you don't use an add-on code. You use the initial base code for both. So you'd code 1005 for the ultrasound FNA and 1007 for the fluoroscopy FNA. Now contrast that first scenario directly with example 2. Same patient, same 2 suspicious lesions in the thyroid and cervical regions. But this time, the physician uses ultrasound guidance for the thyroid lesion and then sticks with that exact same ultrasound guidance for the cervical lesion too. Because we have 2 different lesions evaluated with the exact same guidance method, the rules completely change. We use the initial code 10,005 for the first lesion, and that triggers the add-on code, plus 1006 for the second lesion. See the difference?
These coding examples perfectly map onto the real-world clinical reports you're going to be staring at every single day. When you're scanning a physician's operative note, you're basically acting as a detective. You're hunting for 2 massive clues. Number 1, how many distinct lesions were sampled? And number 2, did the imaging guidance modality change between those lesions, or did it stay exactly the same? Your entire code selection hinges on answering those 2 questions.
Let's turn up the heat. Section 5. Mixed case studies. Take a look at example 3. This one is a real head-scratcher. A patient undergoes an FNA of the pleura under CT guidance, which maps to code 10,009. But during that exact same session, the doctor decides, you know what, I need more tissue, and performs a core needle biopsy on that exact same lesion, using the exact same CT guidance. How on earth do you code that? Well, because they are on the same lesion, modifier 59 is completely off the table. Instead, you'd actually append modifier 52 to indicate a partial reduction in services, applying it to either procedure. So you might code 10,009 for the FNA and 3240.0052 for the core biopsy.
Moving to example 4, we've got an FNA on a thyroid lesion under ultrasound and a core biopsy on a lung lesion also under ultrasound. 2 totally different lesions, 2 different biopsy types, but the same guidance. We code 10,005 for the thyroid FNA, and this brilliantly illustrates a really cool quirk of CPT coding. For the long core biopsy, you use code 32408. You actually don't need a separate imaging code there because CPT 32408 inherently includes its own imaging guidance right in the code description. Finally, let's look at example 5, which is definitely our most complex case study. Lesion 1 is a thyroid FNA with ultrasound. Lesion 2 is an axillary muscle core biopsy with fluoroscopy. So we have different lesions, different biopsies, and different guidance methods. For the FNA, you use 10,005, which already includes the ultrasound. For the muscle core biopsy, you use 2026. But wait, that code doesn't include the fluoroscopic imaging. So you have to carefully code the fluoroscopy separately using 77002 and append modifier 59 or the specific Medicare modifier XU to show it's a completely distinct procedural service from the first biopsy's imaging. As we wrap up this explainer, I want to leave you with a provocative thought. Could a misunderstood guidance method completely change your patient's outcome and their bill? The answer is absolutely yes. A single missed detail regarding whether ultrasound or CT was used, or whether it was the same lesion versus a completely different one, can lead to incorrect add-on codes, improper modifier use, and massive billing denials. Your accuracy as a coder is what ensures the healthcare system functions properly and that patients are billed fairly. Keep practicing these rules, master your modifiers, and I will see you all in the next explainer.